最前沿的科学研究
Science
Innovation und Wissenschaft
Szkielca
Достижения
كشف جديد
Szkielce
经典步向
Pesquisa
Discovery.
Rehashing Science. I'm Shen Ning.
And I'm Mehdi Jurfi, and you are listening to a Fireside Chat episode of Science Rehashed.
Hi, Mehdi.
Hi, Shen.
And hello, Kira. Welcome.
Yes, welcome. Today we are joined by one of our writers, Kira Brenner.
Hello, Shen and Mehdi, and to our listeners. Thank you for letting me do some co-hosting for this episode. I'm excited to join in on this side of production.
Absolutely. Happy to have you. We have got a great guest today for our Fireside Chat. Professor Emery Brown of Mass General Hospital, Harvard, and MIT. He's an anesthesiologist, PhD in statistics, and more recently began computational neuroscience research. Shen, will you tell us a bit more about him before we get into our interview?
Yes, of course. So Professor Emery Brown grew up in Central Florida in a small town called Ocala. When he was in 11th grade, he transferred to Phillips Exeter Academy, a highly selective preparatory school in New Hampshire. From there, he went on to Harvard for his undergrad degree and then pursued his MD PhD in statistics from Harvard University. Then he went on to do his internship in internal medicine at the Brigham and Women's Hospital and had a year of fellowship research before completing his residency in anesthesia at Mass General Hospital and has been on the clinical staff since 1992.
Professor Brown first became a faculty member at Harvard and Mass General and later also joined MIT as a faculty in 2005. He has presented his research on the intersection between anesthesia and computational neuroscience broad in both French and English. As we will hear more about, Professor Brown's love and study of Romance languages began when he was in high school.
Yes, you'll hear a few instances during our conversation about what Professor Brown thinks is the best way to communicate a specific message and how the language we choose to describe medical procedures matters. My impression is that studying foreign languages gives him a lens through which to think about how doctors deliver information to their patients.
Exactly. He's clearly not just a polyglot, but a true polymath with diverse interests and the unique ability to bring some of them together in an interdisciplinary way.
Professor Brown, welcome. It is a true pleasure to have you on the show today. Before we get into more of your professional career, we'd love to hear about your transition from Central Florida to the environment at the private high school you transferred to in 11th grade, Phillips Exeter Academy. How did that come about?
So let me just go back a couple of years before that. So the summer after my ninth grade, so I was interested in languages growing up. I wanted to be a language specialist, and so Spanish, and then when I got to ninth grade, the high school I was attending didn't have a teacher for second year Spanish, so they did have introductory French. So I took introductory French, and then the summer after my ninth grade year, I went to I spent the summer in France on a travel study program. And so I got to live with a French family and, see Europe. This is the first time I'd been to Europe. So I was 14 at the time. I was traveled with a group of, from all over the United States. There were about, 50 of us. And it was a great experience. So I came back and said, okay, I'm going to continue French. So I didn't have someone to teach second year French. So I went back to Spanish. All right. So now it's summer after 10th grade, and it's like, okay, summer after 10th grade, what can you do now? You've already been to Europe. What are you going to go to the moon next or something? Because, what could top that? So my mother came home with this idea of maybe going to Exeter Summer School to spend time there. So I thought that was fantastic. And I knew about Phillips Exeter Academy. One of my cousins had gone there for a summer program. And also I had a cousin who was actually enrolled there in Phillips Exeter, Louis Whitsett, who was going there. So I went there. It was great. I loved it. The experience was amazing. It was real school. Because the other thing my mother told me, she said, you're doing well here in Florida, but, you really haven't been tested yet, so don't get too full of yourself, So going off to Exeter was probably a good thing for that reason. And I really liked it. And so I was admitted into the regular session. And so But I ended up in the regular session in January of my 11th grade year. It was cold beyond belief. So that talk about total transition and culture shock. That was like total transition and culture shock. But it was good. I mean, I was very lucky. My advisor was a linguist, Aldo Baja. He was into Spanish and French and Portuguese. He spoke Italian. He started studying German later. So, we hit it off really. And I'd met him from the summer school. So we hit it off, very well. And in fact, after being on campus for just one semester, he said, you finished all your requirements. Why don't you go to Spain the second semester of your senior year? So I said, that's a cool idea. So instead of finishing my last semester at Exeter on campus, I spent it in Barcelona, Spain, as part of the school year abroad program. So when I finished up high school, I was very proficient in French and very proficient in Spanish, and I was going to become a linguist, essentially. And a linguist, and also maybe work for the World Health Organization. So that was kind of my goal. And I had this grandiose plan that I was going to learn all the major languages of the UN because I wanted to be, didn't want to be able to talk to anybody. Then I realized that was probably kind of hard. So I decided to learn the languages of the principal colonial languages of the African diaspora. So obviously English, Spanish, French, Portuguese. And then I said, well, you should probably learn one African language too. So I picked Swahili. So that's kind of been my goal.
Oh, this is great. So are you fluent in most of these languages, Spanish, French, Swahili, and currently work on Portuguese?
Yeah, so I turned 60 a few years ago, and I made a pact with myself. I said, okay, what you're going to do this year is you're going to give a lecture in 4 languages. All right, so I did in English, so I do that all the time. So I did it in Spanish. I do that fairly frequently. So I gave a lecture in French in Paris, and then 3 weeks later, I had my lecture in Portuguese. And I had worked very hard. I had the slides all translated and everything. But I hadn't had enough time to practice, to be ready for the questions and stuff. So I wimped. I have to tell you, I wimped out. But I told the guys the next time I'm back there, I still have to do my lecture in Portuguese.
So knowing that you have this passion for learning languages as you entered college, I'm really curious to hear when it was that you decided to pursue medicine in your career.
Well, I actually went to college with the idea of going and becoming a doctor. And what was less clear was what I was going to major in. I mean, I like medicine. I guess it probably dates back to, I was sick a lot when I was a kid. I had, if there was a flu to be caught, I would catch it. So I had a lot of doctor visits when I was a young kid, like in first and second grade. And I had, this is in rural Florida. I had this pediatrician who was like really good. His name was Dr. Butcher. And he used to come in, oh, what's wrong with this turkey here today? Oh, what's up? And he would percuss, he would, tap my back. I was like, damn, I want to do that. That's really cool, Yeah. But I mean, quite frankly, every time I'd see him, I'd be sick. And a few days later, he'd give me some medicine and I'd feel better. I said, God, that's what I want to do. So that's how I got interested in medicine. And then Romance languages and medicine. So that sort of spelled something like World Health Organization or Médecins Sans Frontières. So that's what I thought I would do. And then as I began to like statistics more, I decided I really wanted to get a PhD in statistics. And I really didn't care how I put it together. I didn't have a formula. I didn't. And I said, this is what I want to study. I just think it's cool. It's fun. That's what I wanted to do. And I really think that that's important. I think it's important to change your mind, to do a lot of different things because it only makes you broader. And you have time to do that certainly when you're younger and you can take advantage of those sorts of opportunities. And I'm glad I did. Like right now, I spend a good amount of time, communicating with my colleagues in Latin America. About anesthesiology. And I have the good fortune to have sort of open invitations to a number of those places because they enjoy learning the anesthesiology from it, but they really appreciate the fact that I make the effort to do the lecture in Spanish or what have you. And I think, that's, that like really does it for me. It's fun for me, I enjoy doing it. And, like really getting it right, not just making yourself understood. Like anesthesia, go out. No, no, no. You want to explain it the same way. Like one of my language teachers told me, he said, what you want to do when you're learning a language is you want to preserve your personality in the other language. So you want everything to translate over. You don't want to be muted. And so if I'm funny in English, I want to be funny in French. That's how I got into it.
And why anesthesiology in particular?
When I was in medical school, I guess there were really two things. One is I really enjoyed it. I enjoyed the pharmacology. I enjoyed the physiology. I enjoyed the real time nature of it. You had to make decisions at the moment, and it had to work because situations evolve very, very quickly. And the other thing was sort of more of a personal reason. As I said, I thought I would be more like maybe a general practitioner working in the World Health Organization or something like that. And when I was a Harvard graduate student, MD, PhD student, I was a dorm advisor at Leverett House. That was the house I was in as an undergraduate, and I was back there as a dorm advisor for 7 years, actually. And I had this total open door policy. Anytime you need anything, just come. I'm there. I'm at your disposal. And it was a very good experience for me because it taught me a lot about myself. I realized that that's the sort of position that I felt I should be if I were a general practitioner, if I were, working on the front lines of medicine. But I also realized, but what it taught me was I didn't have the capacity to do that. I mean, I still enjoyed taking care of patients and, giving care and what have you. But I needed something which is a little bit more, I needed sort of more finite. And that was another reason, sort of sociologically, that anesthesiology was appealing. Because it's very intense when I'm there. The patient is all I'm focused on one particular patient, taking care of them in the best way I know how. But then I'm able to leave it and come back. That was good for me psychologically. It was also good for being able to schedule and do research.
This is a super interesting career pathway. So from medicine then to statistics and computational neuroscience. Why is that?
Well, what happened is that I really enjoyed. I did my PhD in statistics, and then that was just amazingly enjoyable. And I didn't know how I was going to. I didn't want to be a statistician that was just helping people plan studies. I wanted to do research myself. And I didn't quite know what that meant because there weren't statisticians around who were sort of doing it basically that way, who had laboratories the same way engineers or biologists would have laboratories. But that's what I envisioned myself doing. And, when I started my career, I was able to get a grant from the Robert Wood Johnson Foundation to set up my laboratory. And I continued working on circadian rhythms as I'd worked on when I was a graduate student. That was what I did my PhD thesis on, and also my medical school thesis. But I realized that I didn't see I didn't see a very long career path working just on circadian rhythms. So I decided I needed to work. I wanted to expand my field a bit, expand my area of applications of statistics. So I actually took a summer course at Woods Hole. I spent the summer there. Once I was a junior faculty member, 2 years on in the faculty, or 3 years on in the faculty at MGH. I took the Methods in Computational Neuroscience course at Woods Hole and basically learned about computational neuroscience. And I thought, this is a fun area. There are cool problems here, data analysis questions, they're nothing like what I studied in my PhD. So it was just a whole new world. So I just took it on. And Matt Wilson, who's at MIT, was working on studying the hippocampus, and they were doing some really cool experiments. And then part of this is just really serendipity. There was no statistics department at MIT. And I was teaching a statistics course in physiology at Harvard Statistics Department at the time. And Lauren Frank, who was one of Matt's graduate students, came over to the Harvard Stat Department to get help with their data analyses. And I was thinking, wow, you guys are coming to me. I planned to come to you as soon as I read enough. I feel like I could have a meaningful conversation with you. And so that was just a bit of serendipity. And that's how I got started on computational neuroscience. And Lauren, said, if you can help me with the statistics, I'll teach you neuroscience. I said, that's a bet, boom, let's do it, so that's how I got started.
If you're enjoying the show and you want to help us keep making the content, please consider becoming one of our patrons on Patreon. Find us at patreon.com/join/science-rehash to become a patron for just $3 a month. Or you can become a VIP patron for just $5 a month. Our first 10 VIP patrons will receive a free Science Rehash water bottle.
Dr. Brown, there are some important distinctions you make between anesthesia and other states of unconsciousness, such as being asleep or in a coma, or as you mentioned, an induced coma, which is perhaps what you view as being the closest comparison.
Well, so general anesthesia, so let me just give you a little definition of general anesthesia. General anesthesia means that you put a patient in a state that's reversible with using drugs so that they are unconscious, they don't perceive any painful stimulation, they're not going to form any memories, they're not moving around, so it's easy for the surgeon to operate. They're physiologically stable, heart rate, blood pressure, body temperature, and the state's reversible, so you use the drugs to bring them in, then you stop the drugs and you bring them out. That's the key thing. And we can think of it as a drug-induced reversible coma because you do have to be insensate in order to tolerate the trauma of surgery, because it really is trauma, or certainly would be if it weren't for the anesthesia. In contrast, local anesthesia is as it sounds. I inject something like lidocaine or bupivacaine into an area, and I numb that area or areas below that, and then I can operate on your leg or I can operate on your foot, that sort of thing, and you could be totally wide awake. So your whole body is not, insensate, just the area where I need to operate or where the surgeon needs to operate.
And I was wondering, how would you respond in terms of comparing anesthesia versus sleep?
So the thing with general anesthesia is, as I said, you're in this state where you're basically in a drug-induced reversible coma so that the surgeon can perform the operation and you're not traumatized by it. Mm-hmm. And so sleep is a physiologic state, which we enter into naturally. And it consists of two main phases, sort of the non-REM phase and the REM phase. So during the non-REM phase, you go through about 3 stages of non-REM sleep. And then you march out of that into REM, and you repeat this alternation between the non-REM and the REM state about 4 or 6 times a night. The whole cycle lasts about 90 minutes. And so this is physiologic. What we know is you need it to be healthy, to maintain immune function, to maintain cognitive function. And also there's some degree of restorative properties of sleep. And also it turns out that it's helpful for memory consolidation. So if we think of the various phases, the 2 phases like non-REM sleep and then REM sleep, so roughly speaking, maybe your brain is resting during the non-REM part and it's doing some work, maybe making some synapses a little more stable, helping you to consolidate memories. So that's entirely different from general anesthesia, where we put you in a state and we hold you like right here in this fixed state so that you can, and there's nothing intrinsically restorative about general anesthesia at all. In fact, it's a man-made condition so that we can provide, surgical therapies, and then non-invasive, and then maybe some invasive diagnostic.
The distinction between anesthesia, sleep, and an induced coma is an important one in your 2010 paper in the New England Journal of Medicine and other publications of yours. Can you elaborate on what makes anesthesia more similar to an induced reversible coma than it does to sleep?
I think it's a very important idea. So anecdotally, most anesthesiologists, when they're talking to patients, they come and say, well, Mr. Jones, I'm going to have you go to sleep for your operation. I mean, if you walked up to him and said, Mr. Jones, I'm going to put you in a drug-induced reversible coma, I mean, that probably wouldn't endear you to Mr. Jones, and he'd probably hop up off the bed and, run away. But I think that's part of the mistake that we make. We try to, we speak metaphorically about what we do as opposed to being direct. So what I would go to him and say, Mr. Jones, I'm your anesthesiologist. I'm going to take very good care of you. During the anesthesia, you're going to be unconscious. You won't feel any pain. You won't be moving. You won't form any memories, but I'll keep your blood pressure, heart rate, and everything totally under control. That's what I would tell him. And what did I do? I gave him a definition of general anesthesia. I didn't try to make it like a metaphor like sleep, because someone who's astute, they'd say, oh, wow, but when you cut into me, won't I wake up if I'm asleep, right? So again, it just shows you how obvious it is that we speak metaphorically. And after a while, as you continue to use the metaphor too much, you realize you really can't say precisely what it is you're doing. And that's what bothered me. And it bothers me every time I hear one of my colleagues, say, oh, you're going to go to sleep for your operation. And it's sort of like, and if you ask them about it, say, why? You say, well, I know it's not sleep. Okay, well then if you know it's not sleep, then just say that to the person in some way that's humane, and that makes sense. So we again, it's our bad habits that have been repeated over time, and they've evolved into this way of talking about what we do, which isn't direct. And after a while, because it's not direct, it means we really don't understand what we're doing.
Can you tell us a little bit more about your research in anesthesia?
So the first thing I've been interested in is just trying to place anesthesia in a neuroscience framework. But I was practicing as an anesthesiologist. And the more I practiced as an anesthesiologist, I noticed this kind of fundamental issue that bothered me. It was that anesthesiology was acting in the brain, but somehow the brain was being ignored.
Yeah, so it really seems like that there's this rather large gap in understanding, about how anesthesia acts at a molecular level within the brain.
Right. It's fitting to see this applies to anesthesia because, like a lot of neuro research, we see the outcome of certain processes and are working to track down how we got there. We return a lot to the question, why is this working?
I think it would be interesting to know how have you used your statistical work within your neuro and anesthesia research?
So my area of expertise in statistics is time series analysis, the analysis of phenomena that change over time, and that's why I was studying circadian rhythms. So they change over time with very regular oscillations. Well, it turns out that time series analysis is exactly what we needed to understand the EEG of patients under anesthesia, because what would happen is you give them the drug, the brain circuits would oscillate, and the oscillatory characteristics reflected the drug you were giving, how much you gave, and the age of the patient. So the techniques that I learned in my PhD research to characterize oscillatory dynamics for circadian rhythms translated over almost directly to what I needed to do to help characterize the state of patients under anesthesia. So again, I didn't plan it that way. It just happened to be a bit of a serendipity. And we were able to work out a very systematic characterization of all the major anesthetics in terms of their EEG signatures. And that was something we published in 2015, essentially showing that, again, that the drugs have these systematic change. Drugs in the same classes have very similar patterns.
It sounds like you're working to pull back the curtain, so to speak, to help the medical community and patients understand what anesthesia really is. So if we're still exploring all these questions with anesthesia today, I imagine early anesthesia was even less transparent.
Yeah, and I think that, it was very interesting because it was, William Morton, who back in the 1840s was a dentist, who realized that he could give patients a a complete dental prosthesis, like essentially a full set of dentures, if he could remove all their teeth. And so at the time, dentists as well as surgeons were measured by how quickly they could do a procedure. And I think he could take a tooth out in about a minute or something like that. And so if you realize that this would be very, very painful, so he was looking for a way to render the patient insensate to that procedure. And the word anesthesia didn't exist at the time. So he, through a various set of experiences, he discovered ether. He learned about ether, I should say. And at the time, ether was something that you kept in a little vial, sort of on your kitchen table or your dining room table, and you took a little social sniff, after dinner. It was a kind of a socially appropriate or cool thing to do. And then there'd be these. There used to be this thing called ether follies, where people would sort of take enough ether and get giddy and pass out. But he was aware of this. He realized that ether had the potential for maybe being something could be used to render someone insensate for his dental procedures. And he proposed it to John Collins Warren. And he's the one who came up with the term anesthesia, because Morton wrote to him and asked him, what should I name this process? And you can find this letter online. Holmes went through a whole different set of terms, and he finally settled on anesthesia. He said that it should be called anesthesia, meaning lack of sensation from the Greek. The adjective should be anesthetic. And he said, well, whatever term we pick, let's realize that it's going to be with us now and for forever in the future. So that's where the term actually came from. It was like about 6 or 7 days after the first public demonstration that it was named. So just to give you the indication of importance, this had spread to Europe by the end of the year and the first of the next year. It was already known and basically being done. So it was a major success. And so that's basically how it came about.
Oh, this is really interesting. So how has anesthesia evolved since the 19th century?
In some respects, not at all, because you know what our primary anesthetics are? Ethers. We're still using ethers: isoflurane, desflurane, and sevoflurane. They're all ethers. So now we've made improvements. We've brought other drugs into the mix. We combine things, specific muscle relaxants. We use opioids to help control pain. We have drugs which are used to control blood pressure and that sort of thing. And we use a range of intravenous drugs like propofol, the barbiturates, to induce unconsciousness, rapidly, or even maintain unconsciousness. But the core practice in the United States is still based on ether. And in that regard, I think there's a lot of potential for progress. And eventually we'll probably have to get rid of the inhaled drugs because they're not friendly to the environment, and especially it's not an ether but nitrous oxide, which is probably one of the strongest pollutants out there, the anesthetic gases. So where anesthesia made I'd say important headway in terms of improving care was in the mid 80s, and this was because of work done in Harvard Medical School. They put in place monitoring standards. And the monitoring standards are very straightforward. They just basically say, for a person having surgery under general anesthesia, you have to monitor heart rate, blood pressure, oxygen saturation. Prior to that, there was no such requirement. You could just give anesthesia, keep your finger on the pulse. If you felt you learned all the things that you needed to learn about the patient doing that was perfect. So those monitoring standards, which were put in place by Harvard Medical School of Anesthesiology across the major Harvard hospitals in 1985, were adopted broadly by the American Society of Anesthesiology in 1986. It became standards. So those are important so in other words, even though we don't know how the drugs are working, we're going to help anesthesiologists watch you closely and make sure that your physiology is stable. That was the solution. And that's kind of been the core of our practice pretty much ever since then.
And what would you say are some of the risks of anesthesia for patients?
So what I'm happy to say is, death due to anesthesia, it's a very rare event. This idea that people are, like having anesthesia is a near-death experience. That's not the case. And anesthesiologists are and anesthesia caregivers are quite practiced at taking care of patients. And, even a lot of it's still empirical, they do a superb job of making sure that patients are safe while having surgery. So that's not the concern. The concern is that, we give anesthesia now, and a high fraction of patients, particularly elderly patients after anesthesia, their brains don't work. That is, they may have cognitive problems, which might be just simple delirium, which could last for a few hours, onto word finding issues that could last for several months or seemingly, not completely resolved. And once you realize that, you realize, okay, we're beyond just being happy that you survived the anesthesia. We solved that problem years ago. What we need to do is give anesthesia in such a way that we return your brain to being as intact as it was prior to you having the surgery. And to be fair, we have to acknowledge the fact that it's not just anesthesia you're receiving, but you're having surgery. You probably have a lot of inflammation as well, and you have anesthesia. So there are three components, three things which are almost perfectly confounded that contribute to the state of someone's brain following surgery. Having said that, though, it's pretty clear that one component of it has to be the anesthesia. And elderly patients are much more susceptible to this because there's a very easy way to think about it. So someone who's 80 years of age, their neurons have been around for 80 years. And with time, the neurons start to break down. So the myelin sheath on the neuron starts to break down. The dendrites don't extend and retract as much. You don't produce as much neurotransmitter. The cell is much more susceptible to oxidative injury. There is less, the mitochondria don't work as well. The cell volume declines. So imagine that happening in every neuron. So the ability of the neuron to transmit an electrical impulse, like an action, is going to decline. So if I want to disrupt that to make someone unconscious, that's going to be much easier to do. Just, sort of doing a back of the envelope reasoning. So by the same token, anesthesiologists realize this. They're not ignorant of this. They realize this, very explicitly. So they give older people less anesthesia to achieve the same anesthetic state. It turns out if you monitor with EEG, you can probably give them even less than what you might imagine. So you have a greater likelihood of helping to have harming the brain less than you would just following sort of standard conventions. But to be able to do that, you have to monitor. You have to use the EEG to track the brain states of patients under anesthesia. And that's something which is not routinely done. It's not part of mandatory care for delivering general anesthesia.
And you mentioned patient age impacts the lasting effects of anesthesia. I was wondering, how about for patients with or at high risk for developing neurodegenerative diseases like Alzheimer's disease? How might anesthesia impact the cognitions of these patients in a long run?
The first time I realized the importance of the impact of anesthesia on older patients in particular. So we won't say anything about whether they have Alzheimer's or neurodegeneration or like that, but just older patients in general. Is one of my neurology colleagues, Brad Dickerson, came up to me one day in the cafeteria, and we were talking about the work that we were starting to do on anesthesia. And he says, Emery, do you know that I frequently get my first consult to see, he's a geriatric neurologist, to see patients. It's after they've had anesthesia and surgery. And, the family comes to me and says, Uncle Harry isn't himself anymore. So you notice that anesthesia was kind of like a precipitating event to maybe the person was already predisposed or they're just getting older. And the fact they had anesthesia and surgery maybe accelerated or initiated, that particular process. And so now this has been studied a fair amount and documented in a number of investigations that the likelihood of someone who, I'll just pick a number over 50 or 60, some sort of brain dysfunction after anesthesia, which could be a wide range of things, is non-trivial. It could be 20 to 60%. Right. So that's something we have to do something about. And if you ask, like, why might that happen? Well, if I take a slight digression and just say, how does anesthesia work? Well, among the many ways that it's probably working is by generating oscillations. The oscillations in the brain's, electrical circuits make it difficult to transmit information. And so, you have normal oscillations in the air, which are low amplitude, high frequency. Then what happens is oscillations get shifted towards these high amplitude, low frequency oscillations, and they maintain them. And they're not natural. And so what happens then is you maintain this pathologic state for an extended period, the length of time that you need to have surgery. And basically, it's not surprising that your brain doesn't work after being in that condition. And in fact, I'm amazed at the brain and how it's able to come back after being in a situation like that. So that's what's transpiring. We need the oscillations because that's how the drugs are working to turn the brain off in a sense, right? But by the same token, they're also perhaps they're potentially harmful to the brain. So I think that's the conundrum that we find ourselves in. And so until we find other approaches which maybe don't operate with that mechanism, that mitigate given the proper way.
Wow, that's really interesting. And given that all three of us are involved in Alzheimer's research and exploring similar questions, we will look forward to seeing your future work on this.
Absolutely. In the last part of our time with you, we'd love to return to your lifelong passion for learning languages. So throughout your career, you've kept up with French and Spanish and even expanded to these other languages. What are some of the lessons that you've taken away from your studies?
Well, I think, and Kara and I were talking about this earlier today. I think that the cool thing about it is it just it just creates sort of a general deference for cultures in general. It just opens up your mind. And the other thing too is like I remember when I was in France and I had to stand in a long line to get my visa stamp so I could, enroll in classes and things. And then it just gives you a much and your whole life seemingly depends upon getting that visa stamp, right, at that moment. And you start to realize, what the situation is like for immigrants coming to the United States. And, it gives you just this insight that you wouldn't have, sort of otherwise.
All right, guys. So we are on Apple Podcasts. And if you want to support us in bringing you this type of science podcast that we've been bringing you, please go on Apple Podcasts and give us a rating as well as some feedback. So I'm curious, what are some examples of why it is so meaningful to you to be able to communicate fluently in foreign languages? I mean, what changes when you deliver a lecture in Spanish or even converse with a friend in French, in his native language, I
just find the languages fascinating because the ability to just communicate with other people on a whole sort of on their terms, I guess, is what's really appealing to me about it. It's not just making yourself understood. It's like, really making them feel at home because, you're at home with, their way of thinking or their way of expressing themselves. I think that's really important. Last year, a couple of years ago, I landed in Paris at the airport and I got in the taxi. And the taxi driver asked me where I was going. I told him the hotel I was going to. I gave him the address. And he says, where are you coming back from? I said, I'm not coming back from. I said, I'm going to. I said, I'm here for a meeting. He goes, oh, you don't live in Paris? I go, no, I'm not from here. I said, I'm from the U.S. He goes, oh, you have no accent. I mean, and that's like the highest compliment they can pay you, because otherwise it's like, let's just say it's not what French people usually say to Americans when they're speaking French. Let me just put it that way, So I was like, yes. And even after 40 years, I still got it, yes. So that's what I obsess about,
Professor Brown, do you have any approaches to studying foreign languages you found to help with your acquisition across different languages?
So I developed this way of learning languages because, as I said, I didn't want to just make myself understood. Emery, hungry, feed me, that sort of thing. I wanted to, I would love a gorgeous meal, please, if I could have one. I wanted to be completely clear. And so I developed this way of learning the language, which was like parsing. So I would say something to you, right? And I would listen to how you responded to me, how you parsed the response back. If you use the expressions that I used when I spoke with you, right, then I learned that I was saying it correctly. If you use this set of different words, then I knew that I was saying it incorrect, then I had to modify it the next time.
I was going to have kind of a follow-up question, because when you said that, how, the technique you use to parse languages, I realized that is exactly what I do during medical school. I actually listen to the physicians and attendings after I've tried to explain or you give a presentation, and I'm like, oh, that I totally butchered it pretty much every time. But every time I would pay attention to the words they use and the kind of order and it could be formulaic or it could be just natural based on their personality. I picked up the things I enjoyed, the way they presented, the way they, the words they use, for example. And I feel like that was very much applicable to medicine. And I wonder if you noticed that as well, and if you're able to apply that technique as you're going through your training.
Yeah, it's true, because it's all part of becoming, we don't grow up being fluent in medical speak, really. I mean, we learn it, right? And so that same sort of process really has to take place. And and for me, when I'd done this in Spain, I realized that I should do the same thing when I was studying French. And so you're right. I mean, I think it's exactly. And then you've seen it. And when you finally give that presentation of the patient, you hit all the major, you figured out what the salient features were. You went through the review of systems in a very systematic and accessible way. And the team may not say great job. They just go, okay, now we can start, but yeah, I did it right, because, they're not lingering on asking me additional questions or trying to figure out data that I didn't provide them. Yeah. So I hadn't thought about that, but that's a great analogy. I think that is the case, very much so.
Thank you so much, Professor Brown. It's been a real honor and pleasure having you on our show today, and I wish you a beautiful day.
Oh, no problem. I mean, thank you guys. I mean, anytime somebody wants to listen to you pontificate about your life, man, that's kind of an honor. So thank you. I really appreciate it. Thank you.
Thank you so much for your time.
Thank you for listening to another episode of Science Rehashed. This episode was written by Kira Brenner, edited by Tavi Pollard, and mixed by Jared Worsoff. The cover art for this episode was created by our creative director, Emma Brand.